Arizona to the Northwest Regional Telehealth Resource Center's monthly webinar. We're a little bit discombobulated because we're at a meeting in Tucson and had some challenges trying to find a place where we could set up, but everything is up and running just fine now. And I want to thank you for joining us today with our discussion about telepresenter training from Seattle's Swedish Medical Center. I think I said this, I'm Bob Wolverton, the program director for the NRTRC. And just a little bit of housekeeping before we get started. First, I'd like to invite you to our next webinar, October 24th. Dr. Tom Richards, who is one of our board members and who has just developed a iPad app for wound care, is going to be discussing with us the methodologies and steps in doing app development. He's been reviewing the most recent FDA guidelines that just came out a couple of days ago, so he'll try to bring us the most up-to-date information he can. In our Adobe Connect layout here, I would like to point out a couple of things. On the right column, halfway down, you'll see a pod named Files. In that Files pod, we have a save-the-date postcard for our upcoming conference in March in Portland, Oregon, and also the slides for today's presentation, the role of a telepresenter. These are available for your downloads at any time. In the pod directly below that, we have a series of web links. One is a link to sign up for our bi-monthly newsletter that talks about telehealth in the region and covers a lot of different issues involved with telehealth. And you can see a link to our conference website, which we'll talk in more detail about the conference as we build up more detail. There's also a link for SurveyMonkey, but Martha will put the SurveyMonkey web page on your screen as we finish our discussion today so that we can get your impressions of today's webinar, and even more importantly, we'd like to have your ideas for what you'd like to see as an educational webinar in the future. To the left, you'll see a chat room. If you want to make comments back and forth, if you have concerns about connectivity or something, this would be the place to put them, and Martha will monitor that and respond. You can chat with everyone, or you can select who you'd like to chat with. And then to the left of that is a question and answer pod. And we'd like to ask you to input your questions there. Pita, as she goes through the process, will respond to your questions probably after the discussion. We think that might be the better way to go with that. So I'd like to introduce our speaker for the day. Pita Nims is a master's prepared nurse with a background in clinical education, including a strong project management component. Pita builds and manages the clinical aspect of Seattle Swedish Medical Center telemedicine programs. Her clinical background is in critical care in the cardiac unit on the Cherry Hill campus, and she received her undergraduate and graduate degrees in nursing from the University of Washington. Pita is also certified as a telepresenter through the University of Minnesota School of Nursing, and she recently completed certification in project management through the continuing education program at the University of Washington. Pita has trained over 30 nurses successfully in telepresenting in Swedish, and I think this is one of the most important webinars that a lot of people would like to see. So with no further ado, Pita, take it away.
Thank you, Bob. I appreciate the introduction, and I want to also thank you for the opportunity to speak today. I'm excited to share lessons learned on telepresenting and also to share with others our journey as to why we adopted the program in the first place. So I have a structure to my talk today. I would like to start with an overview of who we are in terms of the organization itself, as well as how telehealth has grown within our facility and how it led us to adopt the role of the telepresenter, as well as the background behind telepresenting in general. Okay, so who are we? We are based out of the Seattle area. We're started or founded in 1910 by a physician within Seattle, and we've been in existence for over 100 years now. We have over $2 billion in revenue. We've grown to 5 hospitals, and we have 2 ambulatory care centers that are standalones with more than 100 primary and specialty clinics. Over 9,500 employees, and we contribute $145 million annually to community benefits and charity care, which we're really proud about. We also recently in 2012 affiliated with the Providence Health and Services Network, which expands our footprint, so to speak, in partnership with Providence over a 5-state region. So we started with telehealth back in 2004, where we adopted tele-ICU, and I think that's pretty normal for facilities that first bring on telemedicine. Typically they start with tele-ICU, and oftentimes they'll expand into a telestroke program, which is exactly what Swedish did in 2007. And in order to do that, they actually, the original leaders within telemedicine partnered with Massachusetts General. They had a very robust telestroke program. And in that partnership, Swedish learned more about telemedicine, its applications, and then how to adopt it internally from both the technology perspective and also within the clinical perspective in terms of encouraging physicians to adopt this platform as part of their practice. And you will see an overriding theme in my presentation, because telestroke here started internally as well, and we have done that historically with all of our programs, where we build the program and launch it internally, which really allows us to work on workflow processes, get the workflow down, hardwire this practice into the physician's role. And then if external sites are interested in a program, we then know that we can launch it out with success, because we've already done the heavy lifting internally. In 2008, telestroke expanded out to external community partners and into those rural critical access hospital areas where they really needed a stroke certified neurohospitalist, but they honestly didn't have one. And so this was a great way to provide those types of services in those rural areas where there was a true need. And from that, what we found is that not only did those hospitals need access to those stroke specialists, but they also needed help afterwards, after the patient was admitted to their facility and after they received possibly TPA. So what was ending up happening is 1 or 2 days later, after the neurohospitalist saw the patient in the ED for a stroke consult, they were getting phone calls from the attendings and really wanting to know what was the appropriate care for this individual once they had been admitted. And that happened repeatedly. There were more and more requests for it, and it was determined that in order to be able to really provide good quality care to that individual in that rural facility, it made the most sense to develop a teleneurology program where the physician, instead of doing a phone consult and relying on the attending on the far side to give them accurate information, a teleneurology program will then allow the physician in the Swedish site to be able to lay eyes on the patient, make a determination based on their specialty, and provide another level of care for that individual. And by doing that, the leaders within the telemedicine program decided that they needed to expand our capability, and that meant that we needed to bring somebody in to develop a telepresenter role, as well as train to peripheral devices. And for those of you who may be unfamiliar with peripheral devices, they really are the tools that physicians typically use in their everyday practice. So a fundoscopic exam requires an ophthalmoscope, and listening to heart and lung sounds using a digital stethoscope, listening to carotids, looking for bruits, or looking in the patient's ears to assess eardrums. Whatever that physician might need, there are devices out there that fulfill that capacity or capability. but there has to be somebody on the other end that's trained to use the devices. So that's where the role of the telepresenter comes in. Since 2011, when we launched teleneurology at one of our campuses, we've developed over 30 programs. So the wonderful thing about if you get a foundation established in terms of a training program where you have staff, with be it nurse or an MA or whoever else is in your facility that's appropriate, once you bring up a program and you have that foundation laid, you actually can iteratively bring up other programs as well, depending on the complexity of the exam. And I'll go into that further in my talk. So now we're going to do a little bit of a deep dive into what the role of the telepresenter truly is. I'm going to go over the roles and responsibilities, why we adopted this, which I covered slightly just a few minutes ago, who can act as a telepresenter, the background regarding the adoption of this role, why it was developed in other parts of the country, the training needs that I have discovered as I have rolled out telepresenting throughout Swedish, and things to consider when selecting staff for this role, which I think are very important because not everyone is an appropriate selection to telepresent, just as some physicians will never be, telemedicine will not be a good practice or model for them. Some physicians will not adapt well to providing services this way, whereas others adapt to it very easily and quickly and fastly, and they enjoy it and are quite good at it. Same thing goes for individuals who act as telepresenters. Some people adapt to it beautifully, and once they wrap their arms around it, they're very successful at it and do a fantastic job for the physician, and also very much enjoy it. And that's really the kind of individual that hopefully that you can recruit to serve in this capacity. So who are we really talking about here, and where can you actually implement a role like this? Some of the things that came up when I was first developing this role was really, what are we talking about here in terms of, am I practicing within scope of my licensure? What are we talking about in terms of what a telepresenter truly does? What training really would be appropriate for somebody that's going to adapt this role? What's the difference between a facilitated exam versus non-facilitated, and do you need a telepresenter for a non-facilitated exam? What does that look like? And then what education level is needed? We have telemedicine programs in both our acute care settings and our ambulatory care, so it's a role that can be used robustly in either setting. Historically, we have initially rolled out only within our acute care settings. In current state, we have 5 to 6 programs that are acute care based only. We're now in ambulatory care as well, which it easily translates to either. Training really needs to be structured, and I will tell you that's my bias. I believe, because of my clinical educator background, that the reason why we've been successful in training so many nurses, and the reason why we've been able to adopt more programs and successfully more programs, is because the training is very structured. It really is. Current state, we've only trained nurses, but I caution you that you don't just need a nurse to fulfill this role, depending on the complexity of the exam. And I'll go into that further detail later on in my presentation. My recommendation would be to really look at what's needed from the provider, and how does that fit within the scope of practice for your state. And we did do some work with the Department of Health, which I'll go into greater detail later. But validating that you're not putting yourself or your presenters at risk and asking them to practice out of their scope of practice or licensure within your state Department of Health regulatory body is, I think, very important. And then education level, because what a nurse goes through in terms of education and what they can do in terms of the complexity of the exam is different than somebody who's a medical assistant, different than somebody who's a lay person or an EMT. And you really need to tailor that telepresenter to the type of exams that you really need them to do. Okay. Part of the work that was done prior to launching this program was I had to go out and do a deep dive in terms of what we were really talking about here. And I'll be perfectly honest with you. I don't know if any of you have experienced this, but when I was first introduced to telepresenting, I truly didn't understand what they were talking about. I couldn't quite wrap my brain around it. So the American Telemedicine Association has fantastic guidelines that you can draw upon in terms of looking at what those clinical core standards truly are across the nation, what the technical core standards are, and also guidelines around how to prepare the patient. I will tell you, though, that the guidelines are somewhat ambiguous, and I have, after having gone to the American Telemedicine Association conference, as well as speaking to others around the country, they were kept ambiguous for a reason, and that was so that there wasn't too many constraints around who can act as this role based on resources in your communities. You know, the reality is that I live in a large urban area that has a lot of resources available to me. So that means that I am able to tap on the shoulder of nurses to provide this type of role within our organization that isn't necessarily available to everybody. And so that's part of the reason why the folks at the ATA left the core standards very ambiguous, because they didn't want to close out this role as a possibility for your community. But I would definitely, if you're thinking about building a telepresenter program within your facility, certainly go to the American Telemedicine Association website and take a look at the national guidelines for telepresenting. It will be a wealth of good information for you. And then this next slide just tells you that there are other guidelines in terms of programs specific for telemedicine. And we have drawn upon those and with some of the programs that we've built, particularly for telemental health. It's been invaluable to be able to access that as a resource to help build the program and guide us. So what are we really talking about here? And this was, it took me a while to wrap my brain around this, but it really is, the role really facilitates communication between the patient and the provider. And it's both the clinical communication, i.e. if I'm the nurse on the far end and I have a neurologist that's asking me to test the cranial nerves, I need to be able to test the cranial nerves with the patient, all the while making sure that the physician is receiving that information on their end. Because while I'm the one that's facilitating the exam, the physician is the one, or the provider is the one that actually is doing the evaluation. I'm just a facilitator. So it's a very different type of way of communicating in terms of what do you need to make sure that you do so the physician receives the pertinent information that they need on their end to make that appropriate determination for that patient. So that means it's both verbal and nonverbal communication. The telepresenter also is facilitating communication in terms of making sure that the patient's questions are answered, or if the family is sitting there, making sure that their questions are answered, making sure that the physician doesn't miss anything in the room, i.e. you and I both know that a lot of communication, I think it's 90%, is done with body language. And it's a little difficult to pick up on everyone's body language for the physician. So the role of the telepresenter is to help with that process. So they really wear many hats in some respects. Since we use nurses' current state only, their nursing foundation does not leave the room. When they walk in the door, not only they be telepresenting for the physician, but that nursing hat stays on, which means that they advocate as well. So the role is actually pretty complex. I'm not going to read through the responsibilities, but what I am going to do is walk you through what this looks like for them. So within Swedish, we have it set up that when a consult needs to happen, and this is inpatient only, there will be a conversation between the physician who wants to schedule a consult and with the nurse who is the telepresenter for that day. So there's a phone call that happens. And during that phone call, there's a negotiation in terms of when will the consult be done, because the volume is such that we have nurses that have other duties. So depending on their workflow, they will then have a conversation with the physician regarding timing of the consult. They then, once that negotiation has transpired and they've agreed upon a time, the physician will also indicate to that nurse what they're looking for. And the reason behind that is so that the nurse can be prepared in the room. They've been trained to the protocol for this specialist, but it's a comprehensive protocol. They don't have to do everything every time, of course. It's going to be a focused exam. So when they get set up in the room, the nurse already has an idea of what the physician's going to be looking for. So then the nurse goes up to the room and has a conversation with the nurse that's at the bedside, so the patient's nurse, making sure that the patient's going to be in the room at the time that they have determined that the consult will happen, as well as preparing the patient in terms of what to expect, and then asking the patient if they have any family members that they would like to attend at that time. Then, about 15 to 20 minutes prior to the consult, the nurse will then mobilize a cart. We use carts within our hospital because we can mobilize them around the hospital, plug them in, connect them to the internet, and make it so that the physician can connect to any room within that facility. They also, prior to the exam, if there's any peripheral devices that the physician has indicated that they want to use, they'll make sure those are up and running and that there's no problems with them. That's just so that when the exam truly does happen, we want it to go as smoothly as possible for both the patient perspective, the provider perspective, and also for that telepresenter in the room. There's lots of pressure, particularly in the beginning, and you're launching a new program, and when they're new to process, no one wants to fumble around and look like they don't know what they're doing. And so we try to set them up for success as much as possible, which means that there's some pre-work done each time. And then once everything is set up and ready to go, the physician will then remote into that cart and then start the exam. And during that period of time, the telepresenter is managing the room. So they're facilitating the exam, making sure all questions are being answered, making sure that the physician is getting what they need on their end, and also documenting what happens within the exam itself. And then once they're done, they will clean the cart and then mobilize it back to where it's stored, as well as making sure that the family or the patient doesn't have any further clarifying questions. So there's a lot going on during that period of time, which is why in my opinion, the training is so important. I will tell you that the very first consult that a telepresenter does or performs is a little nerve-wracking for them, but interestingly enough, by the time they hit their third consult, they're up and running, and they feel very confident and comfortable with what's going on. This next slide is just an example of the different peripheral devices and carts that can be used. That's inpatient only. In terms of the carts, ambulatory care, you probably don't need a cart. You can set up a PC and use that as the screen for the video conferencing piece of it. And then the different peripheral devices that can be used either in the acute care setting or in an ambulatory care setting. As you can tell, there's quite a varied number of them. And training is really done specifically to the peripheral devices that have been chosen. So part of the training, it literally lets the attendees, whoever's going to be telepresenter, touch the equipment multiple periods of time, so they start building that muscle memory. So that's another way of trying to assure success for them. So like I said earlier, training to the cart and peripheral devices and any troubleshooting. And realistically, a lot of times when things go wrong, it's typically process. And so in real time, we try to make ourselves available to help them troubleshoot if there's any issues going on. And sometimes it is the technology itself, but at least we give them some tools to have in their back pocket in real time, and then obviously we'll follow up afterwards if it's more not process but more technology based issues, and that is incorporated in the training as well. So we go over multiple ways that there could be failures. We also go over processes several times to start hardwiring it to it. And then we train specifically to the protocol of that specialty. And depending on when a program is launched, there may be several protocols that I'm going over with the nurses. I will tell you, though, that a lot of the protocols are very complementary to each other. So even though we may have a teleneurology consult, a telehospital consult, a telewound consult, a telepsych consult, there's not going to be a lot of variances in terms of the different protocols once you have a more complex protocol established, such as teleneurology. So the training actually to the protocols is pretty simple. Or simpler aspect of it is really getting the staff members comfortable with the cart and the peripheral devices and the workflow, transitioning back and forth between those different tools. And now we talk about etiquette. Etiquette's fantastic because not only is it an issue for the nurse on the far end or the staff member, but it's also an issue for physicians or providers. So part of the training that goes in for not just telepresenters but for the providers themselves is body positioning, making sure that they are centered in the screen, making sure that they're panning the camera. They understand how to pan the camera on the provider end to incorporate family members if they're off screen, so that they can have a face-to-face conversation with that provider and that family member. Positioning for the telepresenter to make sure that they're not blocking exam components so that the physician can actually see what's going on. Classic example is deep tendon reflexes, and the fact of the matter is those are difficult to do. And not only are they difficult to perform, but they're also difficult to perform while you're trying to stay out of the way of the camera itself. So there's training that goes around that and an awareness for that telepresenter to really be aware of how they are positioned, and then looping back and talking to that provider, making sure and validating that they got what they needed. And then privacy, something that sometimes we have to really reinforce is making sure that they close that door, close those curtains, and not inadvertently broadcast the exam down the hallway. The other thing is that's also part of the training, is that we script what the telepresenter says to the patient, assuring that their privacy is of utmost importance and how it's protected within our organization. And then documentation, and we have adopted a standard SMART phrase within our EMR where every progress note or provider note that's documented has the sentence there that talks about how it's a secure 128-bit AES encrypted bidirectional video session. And that's based off of the national standards. And having spoken with our risk management folks, that is what we chose to adopt, because it really is about what is the national standard out there. For the telepresenter, this was a more difficult piece of documentation, and full disclosure, it took us a while to wrap our arms around really what was appropriate and what was inappropriate. I was lucky enough to be able to speak to several of my nursing colleagues in other areas of the country who had telepresenters already out in the field, and they certainly helped guide us in terms of documentation. There is multiple education out there in terms of what telepresenting really is, and that was part of what I did as well in preparation for building this role. They do talk about documentation, but once again, it's rather ambiguous. But essentially, it is just what you used in the exam, who was in attendance on both the provider and patient side, and the time of the exam. This is also a great place if you have an EMR in your organization. We actually built a doc flow sheet within our EMR, and we're able to pull metrics from that EMR. Part of it is looking at not only the time of use, but also the duration, and I'll go into that further later on, but it provides us with some really good metrics in terms of what's really our capacity, and how are we going to grow it, and what do we need to do future state. Staff selection. This is so very important, and the very last bullet, emotional intelligence, I can't emphasize enough. So the staff, whoever acts in the role of this telepresenter, really needs to have very strong communication skills, savvy with technology, but not just savvy with technology, but a willingness to learn new technology and not a fear around it. So they may not be as technologically savvy as your children, but they certainly need to embrace technology and be open to technology. Clinical expertise is also important, particularly dependent on the complexity of the exam. So for teleneurology, you really need to be able to be clinically proficient in terms of checking those cranial nerves for that physician, performing the deep tendon reflexes for that physician, and knowing where the landmarks are if you're listening to heart and lung sounds. So there are things that you really, they should be able to at least have a foundation in. You can train to that, and I think you can grow that, but they at least need to have a foundation. And then the emotional intelligence piece. And this, I think, doesn't get addressed very often. It isn't spoken about very often within our community, but my belief is that it's so important because it can make or break your program. That telepresenter is the front line with that patient. So they intersect where technology and medicine and the patient meets. And they can talk the patient out of participating and make it difficult for the provider on the other end as well. No provider is going to want to perform an exam this way if they're meeting resistance or also are tenuous about adopting this into their medical practice, and then they run across a telepresenter who also feels that this is not a good modality and will sabotage your program. So you want somebody who is open to adopting a new practice within their scope of licensure. You want somebody who has very strong communication skills, who's able to think on their feet in terms of if something goes wrong, and who's able to positively interact with both the patient, the family, and the provider without being intrusive. And I think the emotional intelligence piece really speaks to that. We also worked with our Department of Health, and this was very important to us. Telepresenting was new to Washington State. As far as we were aware, there was no other telepresenting program within our state. And one of the things that is always of concern is, are we practicing within our scope of licensure, and what are the regulatory requirements around that? And I'll be honest with you, the Department of Health really had no idea that telepresenting existed, so I ended up working very closely with them. I happened to be able to work with them on an interpretive statement. So within Washington State, we were able to validate and confirm that we're not putting our nurses at risk in terms of what we're asking them to do out in the field for us. And that was a concern that was brought up during training. So the nurses are very aware, and I anticipate that when I am going out and training other individuals who may not be nurses, that they'll be asking me the same thing. And I just want to make sure that whatever I do falls within our regulatory compliance. And this just speaks to the scope. Telepresenting, like I said earlier, you can have a layperson do that depending on really what you're asking them to do. And a great example of this is telemental health or telepsychiatry. You don't need to have a nurse mobilize a cart or set up a clinic room for a patient that's going to have basically a conversation. It's basically an interview, and we call it talking heads here. A layperson can do that just fine, and actually, if you go to talk to some folks in different areas of the country that have adopted this role early on, Alaska comes to mind, Minnesota comes to mind, Wisconsin comes to mind, Montana comes to mind. You don't have a nurse always in those rural communities where there's a huge geographic distance between that patient and the provider. So you can actually train lay people, depending on what you're asking them to do, to perform some of these exam components. It just really depends on the complexity of it. My understanding is that a medical assistant has been trained, at least in Washington State, through the use of the stethoscope, so we can certainly have an MA be the telepresenter for a telecardiology consult where they're just using the stethoscope to check heart and lung sounds. An ED technician is trained to the stethoscope in Washington State. So it really is all about finding out within your state what scope of licensure each level of education in terms of the individual has, and then tailoring that to your program. Do they fit the program? Can they perform those key exam components within their scope of licensure? So I wanted to actually do a deep dive on two of our most robust programs, and the very first one that we rolled out in 2011 was teleneurology. It's a consultating service only, and we made it so that it mirrored the in-person neurology exam. So we needed to be able to train to the technology as well as to those key exam components. And I will tell you anecdotally that working very close with that physician leader, there was concern about, would this really work? Would that telepresenter be able to perform those exam components in such a manner that the neurologist on the other end really felt comfortable in making that determination? And could they do it in an inpatient setting where the patient could be coming in without a pre-existing diagnosis? So they're trying to figure out what's going on with this individual. And we don't have metrics per se in terms of accuracy of diagnosis, but I will tell you that we've had tremendous success in terms of physicians feeling that they're getting what they need in order to make an appropriate determination, and really feel that they're able to assess a complex patient adequately and appropriately, and manage them remotely. And then our telehospitalist program was the next really robust program that used the telepresenter. And this was launched in 2012 to one of our facilities as a small community hospital, really only about 2 miles or 3 miles north of our main campus. But because of the way of the traffic patterns for our area, it takes a good 20 to 25 minutes to travel in between. Current state, the nocturnist, and it's a nocturnal program only, before the launch of this pilot, they were helping their colleagues in the downtown core, and that meant from 7P to 7A there was no hospitalist on site on that campus. They had an ED, so there was an ED doc, but there was no hospitalist physically at this little community hospital. And when you think about the fact that this hospital averaged 1.2 admissions a night, it didn't make sense from a fiscal perspective to have a physician on nights all the time there when they weren't spending a lot of their time admitting patients. Previous to this, if the physician was located downtown and they had an admission at night, they would have a phone call between the ED doc and the hospitalist. The hospitalist would make a determination whether or not the patient should stay at that facility or transfer to the downtown core. If they stayed at that facility, it could be 2 to 6 hours before a physician actually laid eyes on them in terms of doing an admitting exam, which means that while the patient would be tucked in, there'd be no orders written, pain meds would be difficult to get, and diagnostics would not be started until that physician then circled back around and went out to see the patient. And of course, when they're traveling out to see the patient, then that means that there are patients in the downtown core that weren't being seen. And our downtown core, our 2 main campuses, are quite busy. So it was a very inefficient way to cover 2 campuses. When they launched in 2012, it was a pilot program, and they really looked at, could this be doable in terms of really providing accurate diagnoses in admitting patients? And then was it an appropriate platform for this kind of service? And interestingly enough, it was very successful. The pilot lasted for 3 months. We had the physician champion did chart dives in terms of checking for diagnostic accuracy. We've done over 120 admissions since then, and we've only had 1 exam failure. And that was really not anything to do with the physician or even the nurse. It was more of very early on in the program, the nurse didn't realize that they weren't focusing their exam cam correctly, so a patient was diagnosed with trench foot versus cellulitis. And the next morning, the daytime physician that's normally staffed there caught it, started the antibiotics, and there was no harm done to the patient. And since then, that was the only failure we've had. And we've had some pretty high acuity patients, GI bleeds, AFib, CHF, those types of diagnoses, cholecystitis, appendicitis. So all those things that physicians typically see, and there was concern about whether or not you could really accurately diagnose a patient using this modality, were really laid to rest. We really discovered that the nurses could perform an appropriate exam and the physician was able to make that appropriate determination, and it's been very successful, particularly on those nights where things are very busy in the downtown core, and that doctor could then step into one of our rooms that we have set up for a telemedicine consult very quickly, perform that exam, write the orders, get the patient tucked in, order diagnostics, and the patient's care is expedited. So ultimately, not only was the diagnostics accurate, but the length of stay went down during that period of time. One of the things that I spoke of earlier was really talking about pulling metrics from your EMR, and we keep a real close eye on the length of exam as well as the volume. Current state, we don't have nurses that are designated only as a telepresenter. It is part of their other duties as assigned. We just don't have the volume to support that very valuable resource being designated specifically for one role. But as we move forward with our programs and as they become more robust and more actively utilized, we are keeping a pulse on how often that nurse is being pulled away to act as a telepresenter, what's the typical duration of a consult, and do we need to think about training more nurses to fulfill this function, or do we need to think about potentially designating it as a full-time position within the system? Currently, we haven't hit that threshold yet, but I anticipate at some point in time in the not too distant future actually that will happen. You will see that not only besides teleneurology and telehospice, we have telepediatrics in our ED. And we are just launching and have launched the telepediatric intensivists in both the ED and the hospital. I don't have any consults under our belt yet, but that could happen any day. Telewound is a fantastic program. We only have 3 wound care nurses within our facility. We're across a 5 campus organization. And it's problematic trying to provide wound care consults outside of the downtown core for our wound nurses. So Telewound was launched so that you could utilize the equipment. The wound care nurse could mentor that bedside nurse in real time in terms of wound dressing, assessing the wound, what have you, and they can perform that function is part of their regular business day that doesn't require them to get into a car and drive 35 minutes out to that remote campus. And then telemovement disorders is our clinic-based program, and the role of the telepresenter is very similar in our clinic as in our hospital in terms of clinic is going to be scheduled, of course, but they're going to, the presenter will room the patient, set up the room, make sure that all the appropriate equipment has been prepared, educate the patient just as they would in the hospital setting. So there's not a whole heck of a lot of difference between the two. And then part of ongoing program evaluation is really finding out from the patient what this feels like for them. We were very interested and concerned about the patient experience and their perspective. This is something that just because it looks good and we think it's good doesn't mean that for the patient that it is good. And we've been pleasantly surprised. I'm hoping you can read that slide pretty easily. We sent out a questionnaire to everyone who has received a exam this way, asking them specific questions on what that really felt like for them as a patient receiving their care this way. And sometimes we're lucky enough that the patient will actually write comments down at the bottom of the questionnaire, and it's based on a Likert 0 to 5, 5 being the best quality and obviously 0 being the worst. And as you can see, I think our lowest scores are like 4.45. Sometimes the patients will write comments and they range from this exam went fine, but I just don't think it's right, and to I wish I could receive more exams this way, and why can't I see my neurosurgeon the same way I saw the hospitalist when I was admitted, and it needs to be expanded. I would say that overwhelmingly 95% of patients like receiving their exams this way, and it's been a very well perceived and received program within our system. And I have to say the providers, once they get up and running, they like it as well. It's very efficient. So just to wrap up, I've trained 30 plus nurses at this point in time. We have over 30 programs developed. Not all are in production, but we're ready to launch depending on need. And we've been able to facilitate over 300 exams, which has given us fantastic metrics and lessons learned as we've rolled out multiple programs. So the lessons learned were those pearls of choosing that appropriate person to telepresent and how you do that, what you should be aware of, as well as that structured training program. And then, you know, the sky's really the limit. I've been so pleased, I have to say, with how well this program has been adopted. And it's so fantastic to not only work with, and I've been lucky working with fantastic nurses, but I also have had the chance to work with phenomenal physicians. And I'm always very impressed with how well they adapt to performing and interacting with a patient this way. It's delightful to watch them as they very easily transition to, instead of being there at the bedside, to not only be able to connect therapeutically with that patient, but to work so seamlessly with that nurse telepresenter or that staff member, very much as though they were guiding them if they were in the room. So it's been a fantastic program, and I've been very lucky that not only have I been able to draw on others' expertise, but I've been very lucky to be able to be part of it. And so that's all I have. I'm open for questions if anybody has any.
Well, Peter, thanks a lot. That was a fascinating presentation. And everyone that's listening, we encourage you to ask questions. You can enter your questions down in the Q&A pod at the bottom of the screen. I also wanted to let you know that we've added a link in the files pod over on the right side to our call for presentations for our upcoming webinar in March. If anyone is interested in doing a presentation in one of our tracks at our annual regional conference, please download that and send it back into us. Pita, I see a couple questions.
Okay. I don't see anything on my end. So can you tell me, Bob, how to...
Let me just, I'll just give them to you. Lori is asking, for the hospitalist program, is there one designated hospitalist that's responsible for the remote consultation?
We have a physician champion, but no. What I've done is I've gone out and trained all the hospitalists that work at night. So when they rotate in, depending on who's on, any one of them is able to perform a remote admission.
Okay, great. And Nate says, hi, Pita, excellent presentation. Thank you. And with Swedish offering 30 plus programs and a true commitment to telemedicine, and here we go. Can you share whether Swedish is receiving reimbursement from Medicare, Medicaid, insurance providers for these services?
That's a terrific question, Nate, and one that I can address. Essentially, if it's within our facility, we cannot. And the reason why, as I'm sure you're well aware of, we are not in a physician shortage area, and we are in a metropolitan statistical area. However, for any of the programs that we have externally with our partner hospital sites or clinics where they are in a physician shortage area and not in a metropolitan statistical area, then there is reimbursement. Legislation is in effect. Obviously, there's a lot going on in terms across the country of trying to remove that barrier for reimbursement. It's an ongoing issue. I know that 19 states have adopted parity in terms of reimbursement, but current state Washington does not have that. And realistically, the facility or the organization made a determination that this is the future of healthcare. You know, we've got less providers, and we have more people needing this kind of specialty care. And the reality is that there's enough going on across the country in terms of actively trying to change the laws around reimbursement, that the floodgates will open once that does happen. And we want to make sure that we had programs developed so that we're ahead of the game when that does transpire.
Okay, we'll take a few minutes. If you have further questions, please go ahead and enter them in the Q&A pod. And as we start to wind down here, I will let you know that Martha is going to put the Survey Monkey survey up on your screen. And we ask that you fill that out and let us know what you thought about today's presentation, but also what you'd like to see in the future. NRTRC is part of a national network of telehealth resource centers, and we can get information on pretty much any topic that you're looking for. We'd be glad to schedule uh, a future webinar based on our users' questions and comments. I think that's really important to meet the needs of our folks that are out there. We have another question here from Lori. Have you started to expand the hospitalist remote consultation service beyond your organization? And if you have, what are the challenges?
Well, we have not been able to move outside our organization yet, but there are facilities that are very interested. So we're just starting those conversations. Realistically, I can just tell you preliminarily, of course, the technology and interoperability will be a challenge, but we're already trying to address that issue. And then, how are they on an EMR? Can we access that EMR and getting the patient's demographics and their chart available to the physician? And then on the patient end, who is going to be responsible for that patient as they're in-house, and how does the physician, the hospitalist, interact with the nursing staff? So those are all issues that we're starting to address and to really look at how to facilitate and how we can deploy this outside our organization so that the physician feels that it's a safe modality and the patient's well cared for.
Okay, and Libby asks a follow-up question to the previous one about reimbursement on CMS projects. Are you able to get reimbursement from private insurance or from other third-party payers?
Variably, yeah, it's hit and miss. I think that private payers typically follow the CMS Medicare guidelines, and I think that once CMS opens up the parity of telemedicine, regardless of where that patient's located, I think that the private payers will follow suit. But it really honestly depends on the insurance companies. Some will do it 100%, some will have a percentage, and some won't recognize it at all.
Yeah, just as an addition to that, there are a few states in the NRTRC region that have now enacted law that says that private payers must reimburse for the same programs that telemedicine that CMS pays for with full parity. There's a little bit of contention going on in a couple of our states, but it looks like it's going to finally come down to what Pita said. Peter Bryant asks you, who pays for the nurse presenters outside your system?
That's a really good question. And, like I said previously, the volume is such that the nursing staff is part of the nursing staff at that far location. So this follows under that other duties as assigned. I will tell you though that within CMS there are fees that you can recoup in terms of a telepresenter. I think that the fee structure is $34. It's part of the facility fee. So there is money there, but currently because the volumes are as low as they are, there isn't a full-time person designated to telepresent at those far communities, and so it really is just part of their everyday roles and responsibilities.
Okay, if there are any other questions, go ahead and type them in. We're running up against our hour time slot, but I don't think we mind too much answering a few more questions if you have them. If not, you'll see before too very long now our survey, and again, we solicit your input on that. This webinar has been recorded and will be put up on our NRTRC website. That's nrtrc.org. And as soon as all the little bells and whistles are done, we'll put that up forward. It doesn't look like we have too many more questions coming in, Pita, so I just want to thank you very much for your presentation. I think this was great information for anybody who's interested in telemedicine, and certainly a question that we get quite a bit here at NRTRC. So thank you very much. Thank everyone for attending, and there's your survey. Please take it.
My pleasure, Bob, and thank you so much for asking me to participate. It's been a wonderful experience.
Well, maybe we'll do it again in the future. Thank you. Peter, if you're still here with us, we just got one last question. If Judy's around, we'll answer this for her, I hope. She asks for teleneurology. Do the physicians have to legally see the patient first once in person?
No, they don't, actually. It's a consulting service, so they don't have to physically see them. The physicians typically will try to loop around depending on how long the patient's in the facility and timing. But teleneurology is actually launched out at a facility that's probably about 35 minutes away without traffic. And depending on how many neuroconsults are out there at any one time, a physician may choose to go out there or they may choose to conduct the exam remotely. It just really honestly depends, but it's not a legal requirement. I will tell you though that if the patient is in the facility for longer than 3 days, you have to you can only do a consult, a remote exam, once every 3 days. That's a part of the CMS regulations. So if you need to see a patient more than that, then you would have to go out.
Okay, thank you. Sorry about that last minute question. Martha was throwing things at me, and I thought she was just mad at me.
No worries, Bob, my pleasure.
Thanks a lot.
Okay.